Today, I have the distinct pleasure of introducing Dr. Johanna Elumn for this sleep seminar presentation. Dr. Elumn is currently an assistant professor in the Department of Medicine in the section of General Internal Medicine, where she works as part of the SAGE Center for Health and Justice, which is directed by Dr. Emily Wang. And I've had the pleasure of co-mentoring Johanna with Emily on her research over the past several years. The SAGE Center works to understand and address the extensive public health harms of mass incarceration through clinical care, through research, through education, through advocacy, legal scholarship. And its focus is to identify innovative solutions for addressing the health impacts of mass incarceration on individuals, on families, on communities, as well as to produce evidence-based solutions for decarceration, which is the process of depopulating prisons and jails and investing more in community health and in community safety. Dr. Elumn has a very interesting training background. She graduated from Swarthmore College, subsequently received her master's in social work from Columbia University School of Social Work, and then ultimately received her PhD in social welfare through the Graduate Center at the City University of New York. She received sleep research methodology training through an NHL BI program called the PRIDE program, which is a program to increase diversity among individuals engaged in health-related research for behavioral sleep medicine. And it's a summer-long institute program that occurred at the time at NYU. She's received diversity supplements through several HEAL grants that have focused on measures of sleep among patients with opioid use disorder. She's also the recipient of our YCCI Clinical Scholar Career Development Award, and more recently just received her KO1 Career Development Award. And her presentation today is going to talk about some of the work that she's engaged with at the interface of sleep and incarceration. It's entitled Incarceration and Sleep Health Disparities. So thank you very much, Johanna, for agreeing to speak with us today. I will unmute you if I can figure out how to do that. All right, now try to unmute. Okay. Sorry about that. I'm a rookie at these introductions. Take it away.
Thank you so much. So I'm very happy to be here today to talk to you about incarceration and sleep health disparities. Let me bring up my slides.
We see your slides.
Okay, perfect. Thank you. So I have no disclosures, no financial disclosures on this presentation. So I'm going to start out by talking a little bit about my journey and how I got to Yale and to studying sleep medicine. So I grew up in New York City in Hell's Kitchen, in a pretty, at that time, what was a pretty rough neighborhood. But because of the building I lived in and also the educational opportunities I had, I was in some ways shielded a bit from what was going on in the surrounding neighborhood. During my MSW, I ended up working at a community-based public defender office called Neighborhood Defender Service of Harlem. And during that time, spent about 10 years working in direct service, program design, outreach to people who are incarcerated and their families. And during that time, spent a lot of time talking to people and meeting with clients at Rikers Island. And then from that work, really found that I felt I couldn't do as much on the individual level with people because the systems that they were involved in were so difficult to change. And so at that point, went back to get my PhD and transitioned to research, and came to Yale School of Medicine back in 2010 as a staff person while I was completing my PhD, and got connected with Emily around 2015 and started working with the team at the Transitions Clinic at that point and doing research, and have been with that team since that time. So we all know that sleep is a basic human need, but often our sleep is kind of determined by our social circumstances. And so I like to show this quote at the beginning because I think it's very true, especially with this population. And if you think about where you sleep compared to what I'm going to talk about for the people in correctional facilities, that this will really stand out. So when we sleep, where we sleep, and with whom we sleep are all important markers or indicators of social status, privileges, and prevailing power relations. So why look at incarceration and sleep? One of the first things I think to note is that 95% of people who are incarcerated are going to come back to the community. And so they are a population that we need to think about. We can't just think about them as in these facilities and staying there, because most of them are going to come home. And about 45% of Americans have a family member who's been incarcerated. And among communities, among minoritized communities, Black people have about 63% of them have family member who's been incarcerated. And we know that sleep disorders are major contributors to poor health outcomes like diabetes and cardiovascular disease, and that minoritized groups are disproportionately affected by the criminal legal system and by chronic disease. And so I became interested in looking at sleep because it may be a potential mediator of the impact of incarceration on health disparities. And I also think that this work is relevant because it speaks to the circumstances that incarceration creates in certain communities, but it can translate to people who are unstably housed, who have very limited income, who are living in neighborhoods with high incarceration rates and higher levels of violence. So I'm going to start by talking a little bit about sleep and race disparities. So in the US, we know that there are race disparities in sleep health. This is a recent study from 2022 that shows that Black people have higher short and long sleep duration prevalence, and that they're more likely to have sleep apnea, to have short sleep, to have poor sleep quality, and to report daytime sleepiness. And some of this is, some of the things that contribute to these disparities in sleep are structural racism that exists in the United States. So this is a diagram from the American Heart Association that shows, kind of beginning with slavery, how the structures and policies that came out of that system lead to increased burden of health disparities in populations that are minoritized. And you'll see here, out of kind of slavery and Jim Crow, the 13th Amendment created the ability to kind of continue some of those systems through the criminal justice system. So mass incarceration is really speaks to this dramatic increase in the number of people incarcerated in the United States. So between 1970 and 2000, there was about a 400% increase in the number of people who were incarcerated. And this was created by policies and laws that made it more likely that people would become incarcerated. And they were very much based on race and ethnicity. In 1970, you had less than 200,000 people incarcerated, but by 1980, there were 500,000 incarcerated, and now we have approximately 2 million people incarcerated in the United States, and about 11 million people kind of cycle in and out of correctional facilities each year. The US is one of the countries with the highest incarceration rates. And here I've added Alabama and Connecticut because much of the results and the studies I'll talk about take place in those two states. So you can see how Alabama has an extremely high incarceration rate, and Connecticut is more than half of what the rate is across the United States. And we know there are race disparities in who is incarcerated in the United States. So Black people are 5 times more likely, and Hispanic people 2.5 times more likely to be incarcerated than a white person in the United States. And this is for across gender that these rates kind of persist. But you'll see particularly among Black men, the rates are particularly high. This is a kind of a side-by-side of Alabama and Connecticut's incarceration rates. And although Alabama has an overall higher rate of incarceration, Connecticut's numbers actually show that they have a greater disparity in the number of Black people and Hispanic people who are incarcerated. And incarceration is a huge contributor to health disparities, particularly in communities of color. And we know that people coming out of prison are more likely to die, particularly in those first couple of weeks after release. They're 12 times more likely to die from drug overdose, cardiovascular disease, homicide, cancer, and suicide. And all of these causes of death are also linked to sleep in many ways. Now I'm going to talk a little bit about sleep health and incarceration specifically. So those of you who work in the hospital will kind of recognize this, but the hospital is known as a place where there's really often poor sleep because of all of the sounds and interruptions during the night and the health conditions people are experiencing. So this is just a quick, and many of you may be familiar with this, but a quick play of the sound of intensive care unit. In comparison, correctional facilities are often also places where sleep is very disrupted. So in a correctional facility, people are housed in a number of different types of housing units, potentially depending on the facility they're in. This is a photo from a facility in Alabama where people are sleeping in a dorm setting. And so in those kind of settings, you might have 100, 150, 200 people all sleeping in one room in these kind of bunk beds. But people also may be sleeping in a single cell. People may be in solitary confinement, where they're confined to a small cell for 23 hours a day with very little to occupy themselves. And People often suffer mental health consequences as a result of being in solitary confinement. And it also contributes to poor sleep as well. And then even in the double cell, people may report having issues with a cellmate that makes it difficult for them to sleep. And even if their relationship with their cellmate is fine, you're sleeping in a small cell with 2 beds right next to a toilet. Every time your cellmate goes to use the bathroom during the night, you may be woken up. And also in facilities, oftentimes the staff may be going around and checking overnight, or there may be other yelling and disruptions that may contribute to poor sleep. And this is just an example of what it might sound like in a prison in the nighttime.
Johanna, I don't think we are hearing the audio, so you'll have to maybe describe a little bit. I don't know if it's playing through your computer or not.
Sorry about that. So the sound of it is really kind of banging, people talking, yelling, keys jangling. And you can imagine, if you look at the photos, what it might sound like to sleep in a room that has this many people, or in a facility that's housing a large number of people. And this picture kind of also shows that the bed, and the picture before shows that the beds are used for many things other than sleeping, which also may contribute to issues with sleep during the night. So there's a number of things in the facility that might contribute to disrupted sleep. As I described, the cells and the sleeping area, the sleep environment itself. The beds are often metal slabs with a very, very thin mattress. There are often very rigid schedules in the facilities that often are disruptive to sleep. So people often describe being woken up several times during the night for wellness checks. They may have, some people describe getting med call at 3:30 in the morning. In some facilities, breakfast is at 4 a.m. or 3:30. So those kind of schedules can be very disruptive to sleep as well. And then in many facilities, there is constant lights on all night, so that the correction officers can see what's going on. There's often a lot of noise, and people often report very extreme temperatures, or either extreme cold or extreme heat, overcrowding, or just issues in the facility itself can contribute to poor sleep, poor air quality in the facilities, and then people have limited access to green space or to natural light that might help them to sleep better at night. And then there's also the social factors that impact sleep, which is limited access to their family, which may cause a great deal of stress for people while they're incarcerated, social cohesion and disorder within the facility, as well as violence in the facility. People who are going back and forth to court appearances often have to leave extremely early in the morning and come back very late at night. And so that may be disruptive to their sleep. And then many people in the facilities are working, and so those work schedules are very rigid and often involve very early hours as well for people to get up. And then access to healthcare is often an issue in the correctional facilities as well. So during incarceration, people often can't implement the sleep hygiene recommendations that you might give to somebody who's out in the community, to make it a little bit easier for them to go to sleep. They also may have limited access to assessment and treatment. So someone is probably not going to be sent for a sleep study, and it may be very challenging to get a CPAP in a facility. medications that you might give a patient in the community are often not available to people who are incarcerated. And they're often prescribed medications like trazodone, Seroquel, to kind of knock them out during the night. And then when they come out, they're used to taking these medications to get them to sleep and often don't have access to them after they're released. A look at the literature shows that these effects of incarceration also impact the sleep of people who have a family member who's incarcerated. This study showed that people who had a family member incarcerated during their childhood had disrupted sleep duration, so either too short or too long sleep as an adult. And so this is important because we should think also about how having a family member incarcerated impacts the family members who are still out in the community. And they noted that some of it was due to socioeconomic disadvantage and physical and mental health issues, but some of those may also be related to the incarceration of their family member. Another study noted that either having a mother or father incarcerated increased the odds of risky sleep and eating behaviors in childhood, and was worse when both parents were incarcerated. One study noted that those who were unstably housed prior to incarceration had lower prevalence of worse sleep compared to those who were permanently housed before their incarceration. So for some people, there may be some improvement in sleep, or it might not be as bad as the person who was in stable housing prior to incarceration. And another study noted some of the things I've talked about, which is noise from constant movement, overcrowding, inadequate bedding, the lights being on all night, restricted medications, and early wake-up times as some of the things that interfered with sleep when people were incarcerated. There are some limitations, however, to the research that has been done. So many of the studies were not conducted in the United States. And they used the studies all used a variety of methods to assess sleep. Some did chart reviews, some administered measures. Only one that we found used actigraphy to measure sleep during incarceration. And many of these studies were secondary data analysis, and the data came from studies that weren't focused on sleep or incarceration. So further work needs to be done in this area. Many of the studies focused on insomnia, and because of the variation in how insomnia was measured, those studies found insomnia prevalence ranging from 11% to 81%. So there's still a lot of work that needs to be done to really understand sleep in this population. And because most of the studies focused on insomnia, there's very little research on some of the sleep problems that may be driving cardiovascular disease beyond insomnia. So now I'm going to talk a bit about some of our current research. I do want to note here that the team at SAGE Center includes people who are directly impacted by incarceration. And so much of the design, data collection, analysis, and dissemination of our research is done by people with a history of incarceration. So I just wanted to note that here before I kind of dive into these projects. So this is a conceptual framework that I adapted from the socio-ecological model focused on cardiovascular health. And here I've added this section focused on incarceration. And so this is really pointing to how the correctional facility, social context, social relationships, and physical context, as well as those same contexts after release, may contribute to sleep problems that then lead to health disparities in this population. I'm going to start by talking about the sleep justice study, which is focused on sleep health and CVD risk among people recently released from a correctional facility. So the overall justice study was a prospective cohort focused on understanding population-specific drivers of CVD risk. And so our goal was to enroll 100 individuals released from a correctional facility in Connecticut, and everyone in this study had to have some kind of CVD risk in order to be enrolled. And so as part of this study, we added a sleep component that aimed to look at sleep health in this population and then look at the relationship between sleep and CVD risk factor control. And so the justice study involved a very detailed survey as well as clinical measures that were done with participants. And then we added these sleep instruments, the PSCI, the BRISC, the stop bang, and also included the PTSD symptom scale in the survey. And then we asked people to wear the ActiWatch Spectrum Plus for a week, a smaller subset of that group. And then we repeated the sleep survey questions at 6-month follow-up. And this overall sample was followed for a whole year after they enrolled. So this gives you a bit of an idea of what the justice study participants look like. So most were male, 92%. About 51% were Black, non-Hispanic, 27% Hispanic, and 20% white. 78% were living in some kind of transitional housing, like a halfway house or sober house. And then a smaller number, 9% and 8%, were either living with family or friends or were renting a place to live. And you can see there's a pretty even distribution across educational status, but 24% had less than a high school diploma, 20% had GED, 30% had graduated high school, and 23% had some college. And most of the sample was single, 75%. 66% of the sample reported having no income at all. And 19% had less than $500 a month. So this sample was a very, very low income, as you would expect when people are recently released without any kind of community supports. And 20% reported being food insecure. Only 14% had worked during the week before they enrolled in the baseline study. And about 55% reported that they considered their health to be fair or poor. This is a bit about their exposure to the criminal legal system. So they were about 20 years old at first incarceration. And the length of incarceration, the mean, was about 52.8 months. Many people had spent some time in solitary confinement. And then about 85% were on supervision at the time of the study, and 77% were living in a halfway house. And the majority of participants had about 45% had been incarcerated 2 to 5 times before they enrolled in the study. This goes a bit into the health of this sample. So about 55% reported their general health as fair or poor. 59% were considered obese and 30% overweight. 78% had been diagnosed with hypertension, 47% with hyperlipidemia, and 29% with diabetes. And 19% had a history of cardiovascular disease. And about 48% had some kind of CVD risk that was uncontrolled at the time they entered the study. So one of the things we looked at was we administered the brief index of sleep control. And so you can see here about 25% reported low control and about 35% some control of their sleep. And so the brisk looks at how much control you have over things like when you went to sleep, when you got up, how much time you actually spent sleeping, and your sleep environment in general. We also looked at sleep quality. So you can see about 12% reported very bad sleep quality, and about 25% reported fairly bad. But there were a good number of people who said that their sleep quality was fairly good. In the sample, almost 50% had a moderate risk of sleep apnea, and about 25% had a high risk of sleep apnea. But when we asked people in the survey about sleep apnea, 13% they said they had been diagnosed with sleep apnea in the past, and only 1.6% or 3 participants had actually been allowed to use CPAP while they were incarcerated. We also did some qualitative work in both Alabama and Connecticut. And so I'll talk to you a little bit about some of the results from those projects. So my K, which was recently awarded, is focused on looking at the social and physical environmental factors that impact sleep during incarceration and after release. And so as part of that study, we're doing qualitative interviews with people who were recently released from jail and prison, with administration and staff of correctional facilities and administration and staff of halfway houses. And then we're going to do a geospatial analysis to look at all the facilities, the correctional facilities and halfway houses in the US, and what environmental factors surround those facilities. And then we're going to develop and pilot a measure of sleep deficiency and environment in this population and do a pilot of that. And part of the reason for that third aim was that we found people had a very challenging time responding to the PSCI, because their sleep was so variable often, especially in that time right after release, that they struggled to be able to say kind of how much they slept per night in the last month on average. So first are some quotes around the physical environment in the correctional facility. So this person says, oh, the temperature is, you know what I'm saying? If it's hot, it's hot. It's cold, it's cold. So, I mean, they supply the minimum, but I'm talking about extreme heat. I can deal with heat because I just deal with the heat, but it's freezing cold. And when it's cold, it gets cold. This person also talked about the temperature in the facilities. And part of the reason we did interviews in Connecticut and Alabama was to look at some of those issues around extreme temperature. So this is someone from the facility in Alabama. And she says, it's hot, hot, hot in the summertime. It's like inhumane, real bad. There's a thermometer because a lady has to come every day and check it to make sure it doesn't get past like 130 degrees in there, because I've seen it reach 115. So if it gets past a certain degree, I guess we're almost at death, and then they have to do something about it. There's people getting moved out of there constantly. People would have seizures, and I mean, just on the verge of heat stroke. I mean, it's not being dramatic either. It's that bad. It's horrible. And so this kind of shows some of the extreme temperatures that people are dealing with that are bad for health in general, but also are going to prevent people from getting quality sleep in these facilities. And this person said, you can't sleep there, especially if you go to bed hungry a lot, because breakfast is like at 4 a.m. in the morning. So you're just not going to sleep. You've got to get up probably around 3:30, stand and wait for them to call you. So all that factors in. So you ain't getting much sleep if you want to get something to eat or be hungry. You have two choices. And a lot of people go hungry because they just went to sleep till 11 p.m. at night. And then you got to get up. You get yourself together. Then you got to wait. You got to wait for them to call you. So you're up at 3:30, 3 a.m. just sitting there waiting. And a lot of people described the schedules as impacting them. And this person also talks about being hungry in the facility. So if you're having breakfast at 3:30 or 4, they're having lunch around 10:30, 11 o'clock, and then dinner's at 4 p.m. And so then you don't have any more food until 4 o'clock in the morning. And many people didn't want to get up at 4, so would sleep through the meal. And so hunger also played a part in some of their issues with sleep in the facilities. And this person says they could do a lot to help us if they really wanted to, but they don't. And it does make a person want to fight. If you don't sleep, you probably feel miserable. You get aggravated. And lots of people talked about conflicts arising from lack of sleep. And so you would be more likely to get into a fight with your cellmate or someone else, or have issues with the correctional officers because you were sleep deprived in the facility. And then the social environment. So this person talks about, if you remember the pictures I showed, this person says, people have been passing by my head all day long. I don't know what, every time I wake up, it's somebody standing right there. I can't sleep like that. This person says, they could do a lot to help us if they really wanted to, but they don't. And it does make a person want to fight. This person said, I would have vivid dreams. My dreams, for decades now, have been either someone trying to kill me or I'm trying to kill them, either in and out of prison. And between all the inmate on inmate violence, staff on inmate violence, and inmate violence on staff, there was just different variants of that in the dreams. So this person's describing how the violence in the facility continued to affect their sleep years after they were incarcerated. And this person, who was also someone who had been released and was living with his daughter and had a room of his own, said, I'm more comfortable sleeping on the couch where I know where the door is and I can hear it open. It don't matter if I'm sound asleep or not. If the door opens, I'm up. And so people reported a number of ways that they tried to improve their sleep. This person talks about staying busy, trying to keep themselves occupied so they can sleep. Some people talked about taking melatonin as a way to help them sleep. They said, that's good stuff to take. It's natural. It's not a bad chemical to give you. Then giving you all those other Seroquel and Trazodone, all those medications ain't good for you all the time. But they don't give care. They really don't. And this person talks about not being able to get sleep medication. And so because of the violence, they had a lot of trouble sleeping. And so when they couldn't get a medication, they said, so you can't get a sleeping pill, so you turn to drugs. And then I'll close these quotes with this quote from somebody about what they thought about sleep. So they said, I honestly think sleep helps out with everything. If you get good sleep, maybe your eating pattern is different. Maybe the way, like I said, the way you talk and act to people. Sleep is important. I do think it's because if you don't get this, your mind doesn't relax. I think your mind needs to relax. Your mind always goes and goes and goes and needs that 8-hour break, I think, because that's what stresses people out and they lose their mind. I think sleep, a really good night's sleep, really does help out physically everything. And so just very briefly, these studies are among the first to look at sleep after release from jail and prison. So we talked to people shortly after their release about what happened while they were incarcerated, but also what was happening since their release. We did do primary data collection in this study and included objective sleep measures. It does highlight the importance of including people with a history of incarceration on the study team. So they helped to develop the interview guides as well as do the interviews. And we hope to identify some of the drivers of sleep problems during incarceration. And then by engaging those with a history of incarceration and those who work in correctional facilities and post-release housing, all of those groups can contribute to thinking about solutions to these problems. And so future directions, the sleep justice study is wrapping up, but the KO1 is ongoing. In October, we're doing a session on sleep health at the Tutwiler Women's Prison in Alabama. And we're trying to work to ensure that sleep medicine providers are knowledgeable about this population and kind of what they may be facing as they come out into the community. So we've done sessions with the sleep medicine fellows, and Dr. Lauren Tobias and Lisa Puglisi were part of that effort. And then we also have put in a panel to the American Thoracic Society to talk a little bit about this issue, as well as we have a study going on looking at sleep deficiency and opioid use disorder among people recently released from incarceration. And so I just want to thank all of my mentors and funders, and then to thank the research teams who are involved, the justice study team and my own research team as well. And thank you very much.
That was wonderful, Johanna. Thank you very much for a really eye-opening and thought-provoking review of this topic and sharing some of your own data, the qualitative data and some of the data that you've collected through the justice study. I want to encourage folks to put some questions in the chat, and I'm happy to sort of moderate those discussions and questions. And while we wait for people to do that, one of the things that I was thinking about, Johanna, as you were going through this topic, particularly one of the measures you're looking at, which is the BRISC questionnaire, which gets at an individual's sense of control that they have over sleep. And there was a surprising number of people who did not have that sense of control. And I think that could really be a potent mediator or explanatory variable in this particular population. But I think more broadly, when we consider sleep now as sort of a social determinant of health, that might explain, someone who's working multiple jobs, single parent, et cetera. And so I think we're moving finally in the field of sleep medicine to thinking more broadly about, sleep health disparities, sleep itself as a social determinant of health. But as you were talking, and particularly some of the conditions that you described, that were described by some of the participants in your qualitative analysis, it really occurred to me that we almost need to frame this as a basic human right to sleep. Mm-hmm. Basic human need. And one of the questions that came up in the chat, I think, speaks to that a little bit, which is how much of these preliminary data, how much of a discussion is there going on with facilities about potentially focusing on this issue of health, which could pay dividends in terms of behavioral issues and among incarcerated patients, et cetera. I'm just wondering what dialogue, if any, exists on.
So with the case study, one of the reasons we included people who are working in correctional facilities and in halfway houses was because they are part of the equation, and as a way to get facilities thinking about it. It's not only the incarcerated people, but the staff of these facilities, their sleep is also affected by being in these environments. And so we're trying to get to a place where we can have that conversation. So part of that is doing this talk around sleep health in Alabama is in part for the women there, but also to encourage the facility to better understand kind of how their policies might affect the sleep of the women there. And so we can present some of these quotes and results to them to show the ways in which the facility could very easily change some of these policies. So for example, there's a researcher who's working in juvenile detention, and she's had the facilities change the type of light bulb in the lights so that it's not disruptive to the young people's sleep, or you could change the schedule of the facilities. And it's in the facility's best interest to address sleep because it does contribute to violence in the facility and other problems in those spaces.
Excellent. Well, I'm glad that at least some dialogue is happening and some feedback is getting to some of these facilities. You mentioned light exposure or changing the light bulb setting, and there's a question in the chat about this. I would imagine that given limited access to outdoor light, given the fact that patients also probably don't just sleep at night, they probably are napping in their cells throughout the course of the day, those would have real impacts on circadian rhythmicity and sleep drive and so forth. Can you speak to that a little bit about what we know about circadian biology in patients with is that something that you're going to be looking at?
Yeah, that's one of the things we're hoping to look at, because many people reported that they don't get enough exposure to natural light during the day. And so that impacts your body's ability to get that signal that it's time to wind down at nighttime. And then they have these fluorescent lights on all the time, which also interferes with that. And then people are because they're not sleeping at night, they are trying to nap during the day. And so then that just it's like a cycle where their sleep just continues to be worse because they're sleeping at the wrong times of day as well.
What you mentioned, I think, provided some really striking data in one sample of participants that only like 1% or 1.6% of the participants who had a known diagnosis of obstructive sleep apnea were actually getting CPAP therapy. And there's a question in the chat regarding that. Dr. Lindell indicated that she herself had a patient released from prison. He had a sleep study and asked if he was going to be able to use the CPAP in returning to prison. So what do you have any sense? I think there are some obvious barriers to having a piece of equipment with a wire and tubing and so forth but what are some of the barriers to getting people therapy?
I mean, one of the barriers is that if you have a CPAP outside, they're not going to let you bring that CPAP with you when you go in. So you're starting basically from scratch, and then you have to try to get them to do maybe a sleep study, which in most facilities they're not going to do. I have heard in some federal facilities of people getting sleep studies and getting CPAP, and actually being those people that are heavy snorers being put in their own cell because nobody wants to sleep with them. So they're in their own cell with the CPAP. But that's not happening at most facilities, unfortunately.
Yeah, there are obvious, I think, safety and concerns with having that equipment. But oh my gosh, it's like not allowing a patient to take their medication when they're, a treatment that affects their oxygen levels and cardiovascular risk over time. So one of the, you mentioned the justice study, and I think it's important to provide a little bit of context, because it's such an important question that you and Emily are addressing in that study. That the rates of cardiovascular risk immediately after discharge or after release from incarceration just go through the roof. Like I think you've said in the past, during that 2 or 1 month period post incarceration, where there is a lot of instability regarding housing and living environments, and how much does sleep contribute to that risk? And that's something you're obviously going to be looking at in this study.
Mm-hmm. We want to look at how that period right after release and some of that is a very high stress time. And so if people have spent a number of years in a facility and then are coming out, they have many demands on them, including fulfilling basic needs and dealing with probation or parole, as well as trying to find work and housing. And so that is a very high stress time for people. And they may have spent the last 10 or 20 years in a correctional facility where they weren't getting proper sleep, and so their risk is really heightened. And people also reported in the qualitative work that period right before they came out was also really high stress, because there was so much anxiety around what was going to happen when they got out as well.
Yeah. I would imagine that stress, that insecurity, that all plays a role. But it is interesting to think about how sleep might mediate, which also, sleep deficiency, as we all know, can activate, the sympathetic nervous system, inflammatory changes, and so forth. So I think that's really going to be exciting data to see when you start analyzing some of that study. One of the other things. Actually, we have I'll pause for a second. It looks like there's someone who would like to just sort of offer up a comment, and I am going to do my best to make sure that people can unmute them. You should be able to unmute yourself. If not, I will keep trying to do so. Oh, here you go. I think DM, I'm sorry, we're not hearing you. I'm having some difficulty unmuting you. Are you able to unmute? I'm sorry. If you wouldn't mind, I think it might be a phone interface issue, but if you want to type your message into the chat, I can try to. You should be able to unmute yourself right now. While we're waiting for that message, that comment rather, to come up in the chat, one of the other things, Johanna, I know we've worked with Michael Grandner. He was, I think, involved in your early mentorship through the Pride training. It would be nice to have you sort of maybe talk a little bit about that program, because I think there might be people here who might be interested. Training program and some research and so forth. But aside from that, one of the things that Michael has, he and I think Michael Perlis have been advocating. He came just this past April to speak here at Yale to our sleep program. He has this hypothesis that he calls the mind after midnight, which is, that period from 2 to 4 a.m. in the middle of the night, where our cognitive faculties are not at their are not at their peak, our rational decision making, our emotional, and he's got some really impressive data about suicide risk during that period of time. And the general population, I think there are implications for other types of harms, addiction, substance use. But I'm sort of curious, when you have fragmented sleep and you have populations of patients that are up in the middle of the night with their mind going at 2 to when we're not really supposed to be up and thinking, it makes you wonder about whether behavioral events or things that may happen in this population may peak. It would be interesting to look at that sort of circadian patterns in the middle of the night of what happens in among incarcerated individuals.
Yeah, because I think a lot of the women in the correctional facility in Alabama really described living in that dorm setting, and people being up all night and everybody kind of being up, people using drugs, people getting into fights, all kinds of things were happening for them during the night. And so that is something to think about, is that what happens during that period of time when people actually are not sleeping and are maybe not at their best.
Mr. Or Daniel McNally, I think you were able to come on us. Do you want to make your comment that I think
I'll just offer the comment. I'm from UConn up in Farmington, Connecticut. It's one of Connecticut's other medical schools. And we, in fact, do polysomnography and prescribe CPAP for DOC patients. The process is slow and somewhat cumbersome to work through. There are ways I wish they would do it differently in terms of using home testing for many patients rather than in lab testing. But they're balancing out their concerns about what hardware is available in the general population there and could be of danger to others. We have not had resistance from them about placing CPAP, though, for the patients who were found to need CPAP. So I thought I would just correct that, that in fact, there are a decent number of patients in the correction system in Connecticut who are on CPAP.
Oh, that's reassuring. Thank you for sharing that.
And it does really vary from state to state and system to system whether people have access to those sleep studies and CPAP.
All right, thank you for sharing that. Well, I think we've come to the end of the hour. Johanna, thank you so much for really thought-provoking presentation and really incredible work that all of you guys are doing at the Sage Center. And thank you for your time. Have a good rest of your day, everyone. Take care.